Okay.
Good morning, everybody. Today we have Taylor Chambers and Megan Crane from OHA here with us today to present on youth suicide data update. So, welcome, Megan and Taylor, and I will turn it over to you.
All right, thanks so much, Amanda. Good morning. Good to see everyone here. Um, we are taking the opportunity to do our youth suicide data update from OHA. Um, we again have done this presentation yearly, so for those that you have attended in the past, we do try to um, keep it similar just to help people with the data, and always try to add in some additional information as well. My name is Megan Crane. I use she, her pronouns. I am the Injury and Violence Prevention Program Health Systems Coordinator at OHA. And I will let Taylor introduce herself.
Hi, everyone. Good morning. My name is Taylor Chambers. I use a she, her series of pronouns. I serve as the Public Health Suicide Prevention Coordinator at the Oregon Health Authority and sit on the cross-divisional suicide prevention team alongside Megan. It's good to see so many familiar names here and appreciate you coming out during this kind of ad hoc meeting schedule for the Alliance's data presentation.
So I do want to just frame that again, we are going to be sharing a lot of data today. A lot of that can be challenging to hear. So, this meeting is dedicated to this, but we still invite and encourage you to take care of your own needs, permission to step away, do what you need to take care of yourself. And the slides will be available, as well as the recording, of course, after the meeting. Um, And we will, of course, be happy to take questions, but we'll wait until the end of the presentation to take questions. If you have questions and you want to make sure you don't lose them, feel free to put them in the chat, um, because, of course, we do want to make sure we get to those. Next slide. So today we will be focusing on finalized 2024 suicide death data, which is the most recent finalized data year that we have. And we also will be providing some insight into 2025 data that we know thus far, which is preliminary. To set the stage some today, just a reminder that we're going to be talking about state level public health reporting systems and reports, and that this is just part of the story that helps us tell suicide prevention, intervention, and postvention in our state. Also, just want to recognize that data systems, including what we're going to be talking today, like our institutions, have been developed within systems of oppression and racism. Research and data science are centered around the fallacy that data is objective. This is math. These are facts. Numbers don't lie. While the tools of statistics and data science don't carry inherent biases toward a worldview or group, as soon as people get involved, they start making choices that, if unexamined, reinforce their own perspectives in a way that affects the data outcomes and, by extension, the decisions and actions based on them. We still need to do better at looking at intersectionality between identities and recognizing the compounding factors this can have on health outcomes and health equity. Intersectionality is acknowledging that everyone has their own unique experiences of discrimination and oppression, and we must consider everything and anything that can marginalize people, such as gender, race, class, sexual orientation, physical ability, among others. And while this data is not perfect, it's what available and is one important factor in our work. I encourage those interested in learning more about data limitations to review the state's Adult Suicide Intervention and Prevention Plan, Youth Suicide Intervention and Prevention Plan, and the updated progress and annual reports that we have available. And we have links at the end of this presentation. Next slide. So before we jump into the data, we always want to make a note about when we use the term small numbers, which you may hear when we're throughout this presentation. We use this term in this presentation to talk about small numbers as associated with estimates of lower statistical credibility and elevated risk of a privacy breach. Estimates with few cases can tend to be unstable and prone to misinterpretation. For example, it can be hard to answer questions using rates for some youth suicide trends due to the low number of deaths per year. In this example, we see that the average annual count for 2020 through 2024 youth suicides in remote counties was 4, right here. And we are unable to calculate a reliable rate per 100,000. This is where we need to rely on state and national trends, and regardless of the counts, ensure these populations are considered in suicide prevention, intervention, and postvention activities. However, we want to continue to note that any loss by suicide is too many. Any individual that dies by suicide and their circle deserves to be acknowledged and considered in informing prevention efforts. So again, if you do hear the term small numbers, we really are talking about that from a statistical analysis standpoint. Next slide. So diving into the data, we're going to just take a little, again, the focus will be on youth suicide, but just a little framing around suicide across the lifespan in Oregon. Oregon historically and continues to have a higher age-adjusted suicide rate as compared to the US nationally. Between 2019 and 2020, we did see a statistically significant decrease. And then in 2021, we saw an increase in Oregon as well as nationally, and saw a leveling off of suicide between 2021 and 2023, and an increase in 2024 from 19.4 per 100,000 in 2023 to 20 per 100,000 in 2024. And you can see there was a slight decrease in the average suicide rate nationally between 2023 and 2024. Next slide. Again, we have some more specific talking points around youth at the end of the presentation after we've reviewed the data, but just a little bit of summary. And, this is hard to hear and hard to present, but, unfortunately in 2024, we have seen, this is the first time we in Oregon have experienced over 900 suicide deaths. And the first time since 2019 that we've been in the top 10 states for the highest suicide rate. That increase appears to be largely driven by increases in older adult suicide deaths and suicides among Oregonians living in urban counties, which is not typical. Typically, we see these increases in rural counties. We still, of course, have disparities for rural counties, but the deaths in 2024 seem to be somewhat driven by deaths in some contribution from deaths in urban counties. And we did see the older adult suicide deaths, deaths increase significantly. Next slide. Gender and racial disparities persist. Men continue to have the highest suicide rate across all grade groups. And non-Hispanic American Indian and Alaska Native individuals have the highest rate of suicide. We do have LGBTQ IA2S plus data at the state level, but there are a lot of limitations with that data. So we do examine that, and we also look to national data trends where we see disparities existing for individuals that are part of that community. Veterans continue to have significantly higher rates than the general population in Oregon. And we have seen firearm suicide deaths increase between 2023 and 2024, which is a continuing trend in increasing firearm suicide deaths. Preliminary data in 2025 indicate that Oregon will continue seeing an increase in firearm suicide deaths. And then across the lifespan, preliminary data in 2025 indicate that Oregon will see a decrease in suicide deaths for all ages combined. And again, we're going to talk more specifically. We may see some increases for youth in specific ages that we'll get more into. So again, in 2025, we're anticipating numbers closer to last year's suicide rates, so lower than this year, and that includes a decrease in older adults suicide deaths. So again, just want to acknowledge that is a lot to hear, that we do anticipate decreases next year across the lifespan to more similar to what we saw in 2023 versus the increases. We don't anticipate an increasing trend that we saw this year. And it is still significant and still something that is hard to hear. Next slide. So now kind of focusing some on youth. As a reminder, in Oregon, we define youth as 24 and younger, and we will talk about some different age breakouts throughout this presentation. Here you're seeing suicide numbers, rates, and rankings, national rankings change from year to year. Again, the best way to really study this data is look at tracking trends long term. Between 2011 and 2018, Oregon youth suicide deaths increased dramatically. Since its peak in 2018, Oregon's youth suicide rate has had a decreasing trend. We'll see that drawn out on the next slide. In 2024, there were 101 youth suicide deaths compared to 102 in 2023. In 2024, Oregon's suicide rate was the 15th highest in the nation. And just as a note, because this slide says 10 to 24, we do track suicides for ages 9 and under. However, some states do not track this, and therefore, to be comparable to national levels, and for state ranking purposes, we separate out deaths for ages 9 and under. And you can see in the notes in the slide and in the Youth Suicide Intervention and Prevention Plan where we note suicides that we have seen for ages 9 and under. Next slide. So as I stated, we have seen a decreasing trend in youth suicide since a peak in 2018 with a rate of 16.9 per 100,000. And between 2023 and 2024, unlike data that we saw across the lifespan, we saw a decrease. Oregon's rate of youth suicide in 2024 was 13.2 per 100,000. So the green line on the slide here, compared to the US average, which you see here in orange, of 9.7 per 100,000. Next slide. So now we're going to look at charts kind of breaking down the age group. So when we look specifically at ages 10 to 27, we did see an increase between 2023 and 2024. An important note here is just that, we're sharing this data. Again, we are talking about small numbers from a statistical standpoint. And so that's why you see the line here kind of dramatically go up and down. But it is important to acknowledge that, of course, we saw increases between 2023 and 2024. We anticipate a decrease here in 2025. And again, this includes 10 to 17. We acknowledge where youth suicide deaths below that took place, but not on this chart to be able to compare to the national average. Next slide. So here we're looking at 18 to 24-year-olds by year. For Oregon, again, in the green, and the US in orange. And we saw a decrease between 2023 and 2024 for 18 to 24-year-olds in Oregon, and a slight decrease or leveling off for the US average as a whole. Deb, did I say something? Did I speak incorrectly somewhere?
I heard 10 to 27 years.
Okay.
And I knew you meant
10 to 17. Yes.
And I knew you meant 17, so I just wanted to put it in the...
Thank you, Deb. I appreciate that.
No problem.
All right, and now I'm going to turn it over to Taylor.
Great. Thank you so much, Megan. And thank you for sharing some of the broader context of suicide, both across the lifespan and for youth. So I'm going to spend some time reviewing the characteristics of youth suicides in Oregon. This table that we're looking at now is pulled directly from the YSIP annual report. Once again, that's a Youth Suicide Intervention Prevention Plan, and shows some of the characteristics of youth suicides for those aged 24 and younger in Oregon. We're going to dive deeper into these characteristics in the following slides, but important to note here that those aged 18 to 24 made up 72% of the total youth suicide deaths. So looking at the bigger picture in Oregon, here is a chart of age-specific rate of suicide by binary sex from 2020 to 2024. For men, seen here in teal, suicide rates generally increase with age, while women, seen in orange, see an increase between ages 50 to 59, and then see decreased rates later in life. And men continue to have the highest suicide rate across all age groups, with their risk peaking at age 85 and older. Women's suicide rates rise with age and peak between ages 55 to 59, as we see. So this slide is an Oregon-specific comparison between age 10 to 17 in blue and those 18 to 24-year-olds in orange. And this is looking at by sex from 2020 to 2024. We see that in this visualization, males aged 18 to 24 have the highest suicide rate at 36.5 per 100,000. It's important to note here that what is called sex in Oregon Violent Death Reporting System refers to the individual's gender identity at the time of their death, and it includes transgender identities. There is a separate variable for noting if an individual was transgender, and a person can be identified as male or female and also transgender. This data point was added to the data system in 2013 nationally. However, in February 2025, this variable was removed from NVDRS collection. However, Oregon began collecting this data outside of NVDRS, beginning with 2023 data onward, to not lose this important information. While we are not able to provide a rate per 100,000 here by age category due to the low count statistically speaking, we note that there were 16 transgender deaths across ages in Oregon in 2023. This is the most recent year that we have this demographic data available for. So while mostly we're talking about data through 2024, specific demographic data is only available through 2023. And this is a limitation to the visualization that we cannot visualize the transgender deaths here. And additionally, our collection tools do not identify non-binary and other gender non-conforming deaths. We hypothesize that there is likely an undercount on gender identity data in this data system due to the data collection issues, as well as relying on friends and family to provide an individual's gender identity, which may or may not be truly accurate of the person when they while they were living. So as I mentioned, OHA is not able to evaluate transgender suicide rates. We are also unable to produce rates by sexual orientation. However, we can look at counts from 2018 to 2023 by age group. Once more, this is just the most recent data we have available for this demographic information. So noting that sexual orientation here includes gay, lesbian, bisexual, or unspecified gender minority. And while we are not able to evaluate suicide rates by sexual orientation or gender diverse or expansive identity, national evidence tells us that people in and of gender diverse and expansive communities are more likely to attempt and to die by suicide. It's important to note that being a member of this community does not inherently increase one's risk for suicide. Rather, those broader issues, including transphobia and homophobia, acceptance or lack thereof from families, trauma of experiencing rejection, and not having access to gender-affirming healthcare are the risk factors. As a result of being unable to evaluate rates here by the state, we need to look to state and national surveys and trends. So according to the 2025 annual National Trevor Project survey, 36% of LGBTQ plus young people aged 13 to 24 seriously considered attempting suicide in the past year. And 40% of transgender and non-binary young people seriously considered. When evaluating LGBTQ plus young people of color, they reported higher rates than their white peers. It is important to note, though, however, that LGBTQ plus young people who reported living in very accepting communities attempted suicide at less than a third of the rate of those who reported living in very unaccepting communities. Once again, showing that acceptance is a huge protective factor when it comes to suicide. We can also look to Oregon-based surveys as well. So available data from the most recent Oregon Student Health Survey was conducted in 2024, show that students who have an identity other than straight or cisgendered reported higher levels of depression, self-harm behavior, and suicide attempts than their peers. So this graph can be a lot to look at, so I just want to give you a minute to orient to this graph. You'll see sexual orientation on the left-hand side. The bars going across represent percent of students who reported considering suicide, showing sixth grade survey results in purple, eighth in teal, and 11th grade in golden yellow. Here then that you see across grades, students who identified as non-heterosexual reported higher rates of considering suicide compared to their straight peers. And I do want to note that this is 2024 data. However, the 2025 Student Health Survey data is projected to be released in June. So that's just around the corner. We should have that new data available. Again, giving you a minute to orient to this graph, you'll see gender identity on the left-hand side. The bars going across represent percent of students again who reported considering suicide. Once more, showing sixth grade results in purple, eighth in teal, and 11th grade in golden yellow. Here we see that around half of students who identified as transgender and about 1/3 of students who identified as gender expansive had considered attempting suicide. And noting from the previous slide, over 1/3 of students who identified as having a sexual orientation other than straight reported having considered attempting suicide. These important surveys help us to understand that the youth in the LGBTQIA2S+ community are more likely to attempt and die by suicide than the cis and heterosexual population. Again, it is important to note that this is not due to how individuals identify. Rather, this is often due to mistreatment and stigmatization in society. We also recognize and acknowledge that the data systems we have do not capture the complexity, culture, richness, and diversity of people in Oregon. Data on race and ethnicity are used to identify health disparities and measure progress towards achieving health equity. Historically, the focus has been on having people categorize themselves according to prescribed groups instead of how people self-identify based on their own lived experience. For instance, the federal government defines race and ethnicity as two distinctly separate entities, although many people may view them as interchangeable and may not distinguish between the two. Family and friends of someone who has died by suicide are expected to choose only one category that kind of best represents who the person was, when that may or may not resonate with them or accurately reflect multi-ethnic or multiracial identities. In population-based surveys, certain racial or ethnic groups are often aggregated to allow for more robust numbers for analysis. However, broad racial and ethnic groupings often mask important differences between more granular ethnic groups and do not acknowledge important differences in culture, custom, healthcare beliefs, and practice. That said, we will begin to look at race and ethnicity data. So we want to take a closer look at the state's youth suicide death data by race and ethnicity. Note here that we are showing counts as opposed to rates, so we can see the data on all race and ethnicity categories for which we collect data. If we were to look at rates, we would not be able to calculate the rates overall for each of these categories listed. So looking at the chart on the left and at the dark blue total line, which is the top line there, we see that there has been a marked decrease in the total count or number of deaths in youth 24 and younger since 2018, which is where this chart starts. There were 129 deaths in 2018 versus 101 deaths in 2024. This overall decrease has largely been driven by the decrease in number of deaths among white, non-Hispanic youth and adolescents during this period. However, just by looking at the chart on the left, it is hard to discern a trend in suicide deaths among differing race and ethnicities. When we remove both the total and the white non-Hispanic population from the data, as is the case in the graph on the right, we get a better sense of the count of deaths and trends among communities of color and American Indian Alaska Native youth and adolescents. In contrast to the steadily decreasing trend among the white non-Hispanic population, there is no discernible decrease for any communities of color and American Indian Alaska Native youth and adolescents during that same time period from 2018 to 2024. In fact, the trend from 2018 through 2024 appears to be relatively flat or slightly increasing for most communities of color and American Indian Alaska Native youth. However, we did see a decrease between 2023 and 2024 in Hispanic youth suicide deaths. However, more data across years is needed to better understand if there is a trend here. So, keeping in mind that these are counts and not rates, we need to look at national data to include an analysis to understand youth suicide rates for different populations over time. Looking at this data, then, we see that non-Hispanic American Indian and Alaska Native youth have consistently higher rates of suicide compared to all other race ethnicities. And the non-Hispanic white also has a similar trend at the national level. Um, of a slight downward trend, while the rates of youth suicide among Black youth has been increasing steadily over the same time period across the country. So again, looking at national data there. Here again, it's important to note that a person's identity in and of itself is not the risk factor. Rather, historical disenfranchisement through genocide, institutional racism, and white supremacy culture are key factors. These social determinants of health intersect to create a situation that is detrimental to the physical and mental health among communities of color and for the American Indian and Alaska Natives. Further, cultural disconnection, alienation, and pressure to assimilate all contribute to higher rates of suicide among American Indian and Alaska Natives. Importantly, there exist very powerful cultural protective factors that we can and must lean into to further protect youth populations. So we also see disparities in suicide deaths when we look at various geographic areas. This slide is similar to the one Megan presented at the beginning of this presentation. So due to the overall low counts for youth, we're unable to calculate a reliable rate for remote suicide deaths for youth in remote counties or areas. But we see that on average, 4 deaths took place annually in remote areas from 2020 to 2024. While we see that on average, 22 deaths took place in rural counties compared to 76 deaths in urban counties, the average annual suicide rate for this time frame was higher for rural counties as a result of population size. So now that we have more context on who is dying by suicide, it's also important to consider how are people dying by suicide. For youth 18 to 24, they mirror our adult population, dying by firearm most often. However, when we look at youth 10 to 17, we see hanging or suffocation as the most common means, followed again by firearm deaths. We also note other deaths here, look at poisoning, falls, hanging, etc. So we've just taken a deeper dive into some of the death data, but to further contextualize suicide, it's important to consider ED or emergency department and hospitalization data and not just the death data. So here's where we're looking at the publicly available emergency department data from the Hospital Administration of Oregon. This is administrative discharge data, so relies on billing codes. And here we see emergency department visits as a 4-year average rate by age category and sex in the top left, with females represented in orange, while males are represented in blue. And contrary to the death data, we see far more cases of suicide-related visits in females as opposed to males ages 10 to 24. I do want to note that the emergency department rate for 9-year-old and younger populations is higher for males as compared to females. It's very hard to see on this graph. It's the furthest left-hand columns. But again, these are small numbers, statistically speaking, for an average of 5 females and 8 males over the 4-year time span. Because of limitations in the data sets with respect to how sex and gender is collected, only male and female categories are shown. In hospital and emergency department data, the available choices only include male, female, other, unknown, and refuse to answer. This too results in undercounts of non-binary or gender diverse individuals due to deficiencies in data collection. Additionally, the underlying counts for other, unknown, and refuse to answer do not meet data confidentiality thresholds and have been withheld to protect an individual's privacy. If we were to look at hospitalization data as opposed to the emergency department data, we would see similar trends between age groups and sex. However, those rates and counts are much smaller overall. And then looking at the bottom right chart of average rates by race, we do see disparities in the data among American Indian and Alaska Native and Black young people. And that dashboard that I mentioned will be available in the last slide, and we can put that in the chat too. So then this is a summary of suicide-related visits to emergency departments and urgent care centers for all Oregonians under 18 through the Oregon Electronic Surveillance System for the Early Notification of Community-Based Epidemics, or ESSENCE data. It provides real-time data from all non-federal hospital emergency departments and select urgent care centers across Oregon. Included in this visualization is emergency department and urgent care center visits for self-harm, suicide ideation, and suicide attempts. Here we see suicide surveillance data from 2021 through 2020 or 2022, excuse me, through 2026 for youth under 18. The blue bold line is the 2026 data. This data continues to show the seasonality we see in suicides with the school year in youth, with increases in the spring and fall. So now we're going to look at the same years of data, but for the youth 18 to 24. Once more, the blue bold line represents 2026 data. We see slightly similar visit counts for this age group so far in 2026 when we look at the years past too. And just as a note with this dashboard, this is publicly available and you can explore data from 2019 through 2025. So more data is available. And you can look at age categories, including 17 and under, 18 through 24, 25 to 54, and then 55 and older. So, in summation, when we look at the youth suicide death data, Oregon has continued to see variation in suicide rates in 2024 by county, with some counties seeing increases in suicide and some staying stable or decreasing. As mentioned throughout today, disparities remain by demographics in our data. Overall, our suicide rate of 13.2 per 100,000 for youth is still higher than the national average of 9.7 per 100,000 for 2024 data. I also want to touch on what Megan mentioned at the beginning of the presentation is that right now, based on preliminary data for 2025, we are seeing an increase in youth suicide rates. This is largely driven by 18 to 24-year-old deaths. However, finalized 2025 data will be available in the spring of 2027, so we will know more about what the deaths look like then and to better understand the demographics and trends we may see. Overall, the OHA's suicide prevention team remains focused on working to prevent and reduce risk factors and increase protective factors for all youth in Oregon and their families. Okay, I'm going to turn it back over to Megan to talk more about how we can find this data.
All right. I'm going to take a big breath so everyone else can as well, if you would like to, just because that is a lot of data. All right. So we also just wanted to touch base again on where you can find data. So the 2025 Youth Suicide Intervention and Prevention Plan Annual Report and the Adult Suicide Intervention and Prevention Plan Progress Reports are coming shortly. The YSIP Annual Report should be any day. So that's why it's coming soon. So you're getting a little bit of a view of a lot of the data from that report. And again, it should be, I think the plan is for it to come out this week. And of course, as soon as we get that link, we will share it with Amanda to share with the Alliance, and we will get it out through the OHA Suicide Prevention Listserv, and it will be put on the OHA Suicide Prevention website, which we highlight here. Next slide. So again, I put in the chat the link to the OHA Injury and Violence Prevention Program dashboard overview. So again, that includes our dashboards, which are broader than suicide, to include other areas that injury and violence prevention focuses on, such as overdose, falls, drowning. But there are listed in this suicide-specific dashboards, and it's organized by topic, so you can look for suicide. We also have embedded in this link, and it's in this presentation, but we also have the Injury and Violence Prevention Program Data Glossary, which again just helps kind of talk through some of the different data systems, why they may be different, not necessarily one better than the other, but just what are the pros and cons of using different data sets. And the biggest takeaway from that is just when comparing data, you want to make sure you're using data from the same data sets. Next slide. One thing, again, that I kind of started talking about is that the dashboard overview talks about data dashboards and the underlying data sources and kind of the trade-offs on timeliness versus detail, right? So often we can provide more timely data, but it's not going to have the in-depth demographic data, which takes more time to process. So again, the dashboard overview for each dashboard kind of tells you how the balance of timeliness versus detail is considered in the data sets used in that data dashboard. Next slide. So today we've really shared what is only part of the story, as we alluded to, right? We've looked at high-level data that looks at suicide-related events, which has specific uses. Um, we do have the OHA in Oregon has administrative rules and statutes, which I put a link in the chat to standardize collection of race, ethnicity, language, and disability, what is referred to as Real D, and sexual orientation and gender identity, or SOGI data. And so there are efforts for better data collection on those avenues, and the work going into that on the OHA website. This high-level suicide-related data is helpful to be aware of and track, but it alone is insufficient to answer program and training evaluation questions. There are so many other data sources that help us tell the story, data on local projects, survey data, community designed and led data, and evaluation, among others. As a reminder, the 2024 National Strategy for Suicide Prevention has two strategic directions that speak to this work. Strategic Direction 3 and 4, which focus on surveillance, quality improvements, and research and health equity in suicide prevention, which specifically looks at implementing comprehensive suicide prevention strategies for populations disproportionately affected by suicide, both in terms of highest suicide rate and communities with highest increasing rates of suicide, with a focus on historically marginalized communities and centering persons with suicide-centered lived experience to help guide the work. We have embedded these into the Oregon Suicide Prevention Framework, which you can find on the OHA Suicide Prevention website. And we are intentionally focusing on increasing and you'll see here on the slide, those 3 sub-bullet points are really where we have embedded this into the Oregon Suicide Prevention Framework in terms of understanding and focusing on the need to increase publicly available and timely data and support diverse communities to provide their wisdom on policy, program, and training, adaptation, and development. Next slide. I think it's also really important that we acknowledge that we are part of a much bigger picture in terms of looking at social and structural determinants of health and how that affects suicide. I know it's a little hard to read all of it, but on the left here, this comes from Suicide in Politics, which was looked at basically pulling excerpts from documents from United Kingdom suicide prevention policies and mentions of suicide in UK's Parliament and assemblies, and then asked members to kind of examine that and kind of from an art perspective. So this collage, it was created by Alex, which includes ripped pieces of a self-care article. In it, Alex critiques the tendency of people living with suicidal distress to be pointed towards self-care rather than considerations being given to the structural roots of suicidal distress. They said, quote, "We know that these things can lead to suicide, so why is suicide prevention only focusing on crisis and not focusing on prevention and getting to that point?" And I wrote stuff like housing and healthcare and employment and different things that can actually prevent getting to a crisis point, end quote. So again, everyone in this room, or many of us in this room, recognize this and are doing work in this area, but I think it is important to highlight, and that we have to work with partners to do this work, that we, as in suicide prevention, intervention, postvention alone cannot solve the housing crisis, cannot create economic stability for individuals. But these are the protective factors that have evidence showing suicide risk, including economic housing stability, healthy relationships and feeling connected to others, availability of consistent and high quality physical and behavioral health care, and connecting to and acceptance of an individual's cultural identity. Policies that improve economic security and policies that prohibit discrimination on the basis of sexual and gender identity, race, and ethnicity can support individuals from becoming at risk of suicide. Improving access and delivery of healthcare, including mental health and suicide-specific care, can help reduce suicide deaths in Oregon by identifying risk early and putting supports in place, ensuring that culturally infused care is available, which includes ensuring a workforce representing diverse Oregon communities is needed. When we say culturally infused care, we mean an approach, system, or practice that proactively embeds preferred language and cultural understandings, beliefs, values, practices, needs, and preferences in ways that enhance fit, understanding, trust, and effectiveness, and promoting healthy relationships and social connection, including a sense of belonging and acceptance, can decrease risks of suicide, as well as teaching coping and problem-solving skills from an early age. So that is a lot on this slide, and I certainly feel the weight of this, and I think it's really important to talk about it in knowledge. And again, I think you all have examples. We have some examples of the state of how we're trying to do this work better, and we still have a lot of work to do. And I would just ask all of you on this call to consider how you're connecting with communities, agencies, work going on in these areas to cross-pollinate and understand intersections and opportunities to share work and collaborate. All right, so this was a heavy presentation, and this is only a narrow part of the story of what suicide looks like in Oregon. These kind of presentations can make the hopeful moments can easily be missed, and I want to acknowledge that each of you have a role in creating these moments for so many and doing such amazing work. I want to also reiterate and this is like feels so ironic as we just shared a slide that's saying a bath and a cup of tea don't fix everything, but the importance of taking care of yourself in this work. And so we put up this slide to acknowledge this work is hard. It requires persistence, and looking at data can be challenging to live in and day out. But we also want to acknowledge think about what is the hope that keeps you able to do this work. If you want to put something in the chat, feel free. If you just want to think about that yourself, that's fine. What connections do you have to support you and fill you up? And Taylor and I have just provided a couple things here, kind of thinking about the framing in our sources of strength wheel on the right. There's the garden that my wife and I have put at scratch over the last almost 10 years at our house. Our pup, Rasso, who is kind of our life. She is definitely a human, a fur baby to us. And then my little niece on the right there, who just recently learned how to ride her bike. And so she's obviously not on her bike in this picture, but like so excited about riding a bike and wearing her bike helmet. So maybe I'm also sharing that because from an injury and but just painting. So those are some things which give me hope as well as support in this work. And then I'll turn it over to Taylor.
Yeah, thank you, Megan. And I do see a recognition of the quote I've been captured here from The Boy, the Mole, the Fox, and the Horse. It is such a beautiful book. Jennifer, thank you for sharing that. And this quote says, "I can't see a way through," said the boy. "Can you see your next step?" "Yes." "Just take that," said the horse. I think oftentimes if we think about all of this in context, it can be really hard to figure out what our next step is. But just thinking about that individually and not thinking about how you might have to conquer everything that we've talked about today can be a really important connection for me to keep this work going strong. And then always getting out in nature for me is a source of strength I have as well. So just to end, I'll leave this slide up for a minute before I stop screen sharing, and then we'll take questions as well. As I mentioned, we will send out these slides. We'll have a PDF available for folks following today's presentation. That'll go to Jen and Amanda to share out. And this is chock full of resources as well as our contact information should you wish to get a hold of us. A couple of notes here. The youth line information is listed there, which is run by Lines for Life and is talking to youth for youth from youth. Also recognizing 988 as broadly available, as widely available throughout the country. In Oregon, simply dial or text call 988. There's also an online chat feature. You can also text Oregon to 741-741 and reach the crisis text line. Um, and then the Trevor Project is another great resource. We shared some data from them today. They do an annual survey that can be really important to understand how youth are impacted by happenings in society and how that impacts the mental health of youth too. They have their own crisis line or support line. So you can text START to 678-678, or you can call 866-488-7386. So like I said, we'll share these out. I'm going to stop screen sharing just so I have a chance to review the chat and make sure we capture any questions.
And Taylor, I would just add, we shared a little bit of the Oregon Student Health Survey data in this presentation today. The schools committee, I think in last month or the month before, got a little bit more of a detailed presentation, which Amanda, if it may be worthwhile to send out a link to that presentation as well, just so folks can see that. And I don't know if there was a recording of that, but again, the Student Health Survey has many other questions, things we can look at for protective factors in terms of, do you have an accepting adult in your life? Lots of other questions that, again, are not the specific suicide questions we shared today, but are certainly linked and help us think about, how students are experiencing kind of risk and protective factors in schools. All right. So I know we have looks like we have at least comments and/or questions in the chat.
Yeah, so I'm just going to scroll through and see if we can get to them. First, thank you everyone for introducing yourself in the chat. I think that's really important to learn about who's in the room and to better understand who we have as allies in this work as we go through it. Megan, thanks for sharing out some of the specific links. I've also shared one there as well. I think the only question I see at this time with some comments around it is from Justin Potts. Justin asks, do we have any speculation about why the 17 and under ED visit rate increases in April through June? And I do want to share out verbally some of the comments that have been shared because I think this gets to some of the work that we've been doing and might be similar to things we would say. So Brittany shares, I have no research to quote this, but I will say as a school person, kids feel lots of stress with the year ending. They're worried about grades, worried about how they will end the year. With lots of stress in those areas, there's more peer conflict. Some kids are worried about not being at school and being at home for the summer. Justin shares, thanks, Brittany. Yes, I hold those same thoughts for my district, but definitely wonder about any actual evidence being gathered around this. Since we don't have a rigorous post-hospitalization planning or data gathering process, it only has been guessing at the stressors causing this elevation. And shares a link to an article there, which I've not yet clicked on. And I also want to mention here that Kyle shares some more links to articles related to this as well. So I think those would be relevant for folks to review. Um,
Yeah,
yeah,
and I
go
mean,
ahead.
I'll add this is a national trend. This isn't just an Oregon trend. Brittany, I think you provide a lot of insight. Dr. Johnson, I don't know if there's anything specific you wanted to share, just given your experience.
Yeah, we published a paper, which was the second paper I listed, that showed the trend here in Oregon as well. And there's the other paper, the first one I listed is more recent, and they made a comment that during the pandemic, when kids were not in school, they saw a decrease in kids presenting. And so in the conclusion, in the abstract, the findings of the study indicated the presence of seasonal patterns and an observed unexpected decrease in suicidality among children and adolescents after COVID-19 related school closures in March 2020, which suggest a potential association between suicidality and school calendar.
Yeah, I mean, I
So
think, obviously it is like we see the trend that we see like across years, right? We see this
it's different than
decrease.
adults. too.
Yes, it is very, even for the 18 to 24-year-olds, right? But for 17 and under between June and August, right, we see this decrease. I don't like, is that because there are so many less youth experiencing suicidality in a way that would warrant a visit to an emergency department or urgent care centers? Or is it a lack of maybe not having that school structure in place to potentially identify youth that need that support? So, I think it's an excellent question, Justin, and obviously one I think, you being in a school setting, you've thought a lot about. So I don't know that, I mean, again, I think Dr. Johnson, thanks for sharing those links. I think we are getting to some understanding of this trend and I think what if Jill was here, I think she would say, she, in again, not for every youth, but in general, like we see school as potentially something about the structure of school as a protective factor in some cases to getting youth support when they need it. We don't necessarily see, I mean, because we have again, any suicide death is too many, but because of like looking in Oregon specifically at suicide deaths for youth 17 and under and seeing a similar trend, it's hard to we don't necessarily see that same trend as we see with emergency department and urgent care center visits. But we would do see a spike. I mean, in general, we see suicide rates across the lifespan increase slightly in the spring. So that is true.
Mhm.
Taylor?
Yeah, Dr. Johnson, I was just going to share out. It looks like the links you provided are the same, unfortunately. So if you have a second link for the OHSU team paper, we would love to see that.
Justin, any other now that we've answered all your questions?
No, that's all right. Again, we're just kind of speculating based on these larger trends, and it would be hard. It's a hard data point to gather, right? The whys.
Yep.
So and it does seem like most of the research basically just says, yes, we verified there is a trend, but not really addressing the why questions. So,
Yeah.
and like, those of us that are in schools that are, getting our alerts through our, online monitoring systems and other things, you can guess at what those things are, and that they certainly come down to like going back home or stressors at home and increased pressures, academic pressures at the end of the school year. But from a data perspective, that's just kind of, it's anecdote, not evidence.
Yeah. I don't think, please come off mute if we missed if there was another question or comment in the chat. And of course, also happy to take any additional questions or comments that as folks were reflecting on the presentation. We also welcome any either now or Taylor and I will put our emails in the chat in case you don't have them, but we always welcome feedback on what we're sharing, what would be more helpful, recognizing we may or may not have it. And also that, this is uh, a snapshot of the data that is going to be included in the YSIP and ASIP annual reports, where you can get more detail in those reports. For example, lethal means by age group and binary sex. Like the table will be uh, in the report for you to be able to look into some of those more details. So we do try to make that so it's not 200 pages long, but there is more kind of data presented in different ways in those reports, which again are very shortly forthcoming.
Yeah, thank you so much, everyone, for the time today and the attention to the presentation. Really appreciate the time you've given us. Justin, I appreciate your comment in the chat. It is very helpful to get, challenging to hear, but always welcome. Want to reflect on that. And hopefully, I know this meeting was scheduled for an hour and a half. So if you did take off that next 30 minutes, I would encourage you to connect back to your why and some time for yourself in this moment. If that's, taking a walk outside, not looking at your email for 30 minutes, whatever you can afford to do with your time right now, I would really encourage you to take some of that time to do it.
That's a
All
wonderful
right, well,
suggestion.
we'll kind of stay on as people leave the meeting. But again, thanks for your time today. And yes, we look forward to seeing you in future meetings on I don't think I'm not speaking for Taylor, but for myself, this is never my favorite presentation to give. So obviously a really important data for us to share, but look forward to other meetings where we're all together to dig into the work and do all the amazing work that you all are doing.
Well, thank you to both Megan and Taylor for being here today and sharing all this data. Like everybody said, it may be hard to hear, but it helps inform our work. And we really appreciate you both being here today to share all that information. And I highly recommend folks taking Taylor's suggestion if you can to go take good care of yourself after this and enjoy the rest of your day. Thank you, everybody.
Amanda, could you hang a second so I can talk to you? Great, thanks.